Our next speaker, in a small hospital environment, has taken on another hat. And she didn't have this hat until a couple of months ago, but she's now the director of the Addiction Treatment Services, and I probably didn't name that exactly right, but she can elaborate on that next. Again, trying to address those issues. But the broader topic that she's going to talk about is a little bit related to sort of the provocative thought I laid out there on the table this morning. What happens when CVS and Aetna come together and they have a presence in your community? They're providing services that you generated revenue from before. What happens when they've got more data than you have? Because when you think about not just the net worth, the market capitalization, or the annual revenues of combining those two companies, and of course remember CVS has Caremark inside of it now, and they have nearly 80 million individuals that they manage the monthly prescriptions for. Think about the data, think about the information, and whether or not that creates a competitive advantage for them or not in any market. Data is one thing, turning data into useful information is something else. So think about that, and with that I'm going to ask Tim to come up and introduce our next speaker. Welcome back.
Hey, glad to be here. I wanted to take the opportunity and just kind of build on what Tammy had talked about when she goes to the different departments and says, well, what's happening in this area? How many people are leaving? How many people are you seeing? There's this continuum, and I say some of this because I realize a data presentation is between you and lunch. If there's any more challenging thing for a speaker, I don't know what it is. But I'm trying to encourage you of what value this has. But in the continuum of things of guessing, data, information, knowledge, and wisdom, you'd like to think we're at wisdom. Most rural hospitals are guessing. When we brought Nikki on board, from a data analyst standpoint, she opened doors to things that we had, and there's a tremendous amount of information out there, a tremendous amount of data that we were never tapping into. We were making decisions without it. And it's helped us really guide the decisions that we're making. I will tell you, having her in that role, and it was a real stretch for a rural hospital to add a data analyst. But it has been immeasurable. You can't bring a good idea forward into our organization now without, did you run it by Nikki? What kind of data do we have on this? What's happening in our local market? The whole population health piece brought in these patients that were attributed to us. And with that, Medicare shared all of those patients' spend data. Where do they buy their prescriptions? Where do they go for health care other than our organization? What's happening to them? What's making a difference? So I encourage you from that standpoint. Let me introduce Nikki King. She has been an administrative fellow at Margaret Mary. She is one of the most passionate people about rural health care I have ever met in my life. She's going to have an outstanding career throughout the rest of her life in rural health care, and it is a pleasure to introduce her to you.
You want to wander or you want to stand there and talk?
Probably both.
Okay.
So yeah, my name is Nikki King. I'm originally from southeastern Kentucky. I'm now working at Margaret Mary in Batesville, Indiana. I say that because everybody keeps asking me where I'm from, and I don't know if they're asking me where I'm coming from or if they're trying to figure out where my accent is from. It's really fun when I'm back home because my fiance is an American-born Korean, so I never know if they're asking about his race, my accent, or where we work. So yeah, before we get into this, I wanted to talk just a little bit about what my objectives for this presentation. You know, in my role as a data analyst, it's my job to know things. I know everything. And so, you know, I always joke, you guys might not know who I am, but I know every one of you. You don't believe me. Do we have coffee, regional? I know who your doctor who has the best outcomes is. And do we have someone from Americas? I know the highest volume doctor in your community. So, and that's by Medicare volume. So I know lots of stuff about all of y'all. I know Sylvester, saw you guys in there too. So as we get into this, I wanted to talk about why that matters is, as we talk about the future in rural healthcare here, a lot of people talk about there is no future. They see it, they're planning for what happens when you close the doors, basically is what happens. And, I think that the way that we have and I do think we have a future. And I don't know if anybody else had a grandma on here whose life's motto was "We make do." I feel like that has been the calling card of every rural community ever. Is how do we do a whole lot with a little? Like we rocket that in rural America. We have been doing that for hundreds of years. And the way we do that in healthcare is with data. Because I feel like up until now it's been kind of a throw stuff at it and see what sticks sort of strategy when it comes to services. I don't know what people need. I think I know what people need. Here, we'll try it. Let's see what happens. With data, you're talking about the ability to identify and to meet a very specific need that your community has. And it's not going to look different, or it's going to look very different from the community next to you. But based on our community, our demographic, what do we need to get the best outcomes? How do we get the biggest bang for our very limited bucks? So with that introduction, I'll actually get into the data. So I wanted to start a little bit with opioid data because, passion of mine. But also because I saw a few things that were here that were really interesting. So this is the number of deaths and drug overdoses for rural counties in Georgia. I looked at a lot of this data for a whole lot of people. I've never seen a pattern like this. This is really unusual. See, for example, I put up the urban county overdose rates versus the rural county, and it's population adjusted. So one of the things that was really interesting about that to me is you see those two big spikes on that 26-year-old demographic, that's me, and in that the early 50s demographic. So I didn't know if you guys are familiar with the website called Reddit. It's the life's blood of the millennial generation. This is where we get our news. So I went on there because it's essentially a forum site, and I don't know if you're familiar with the fact that there's actually a forum on there for addicts. They can't sell or anything, but they spread information on there about different things, and a lot of it is information that healthcare providers really need to be involved in because they're telling each other things like where to get clean needles, how to safely administer your drugs, things that they're not going to talk about with their providers, but they'll ask, and so that kind of information is being disseminated. On here, and I guess you can't really see it, which is probably a good thing because there's a lot of bad language that I've tried to get away from there, and it didn't really work. But one of the things that came up on this forums is there are people from rural communities, and some of those communities were actually in this room. We're talking about that young guys in that 20s demographics are going to Atlanta to rap concerts, and they're getting approached to buy drugs there, and they're buying what they think are Percocets, but they're fake Percocets. It lists the specific places that they're buying them, the specific concerts where there's people that are targeting people to sell these to, and that they specifically are targeting them with Percocets because apparently it's the common belief that Percocets are the safest kind of pharmaceutical drug that you can abuse with limited repercussions. They actually posted pictures on there of one of these fake Percocets because somebody had actually bought them from a rural community. And they were talking about how that actually their community was one that had someone in that 50 demographic age range and that 20-something both died of an overdose within like a 2-week span. And that was both related to these fake Percocets. And they looked exactly the same, except the fake ones are just a little bit of a deeper yellow, where the other ones were kind of a more pale yellow. But they really go into the details on this forum. I didn't know if you guys knew that this forum was out there, but there's all kinds of interesting stuff. They're posting alerts on this forum whenever a bad batch comes out. That's really important from a staffing Narcan. Do the EMS people have enough Narcan, specifically when you're talking about these Percocets being laced with something like fentanyl or potentially carfentanil. It takes much bigger doses of Narcan to bring these people back up. So are your EMTs carrying enough at one time if there's a bad dose that's out? So that's out there.
What was the site?
It's Reddit, Reddit. And you can search for, it's /r, like lowercase little letter R, like rabbit, opioids. And then once you get into the opioid forum, you just search in the box for Georgia. And all the Georgia ones will pop up. Before we get into this too, I was also going to talk about behavioral health. And one of the big reasons that I wanted to talk about behavioral health is I always hear from a lot of people that we can't afford to do behavioral health. it's a very low-paying service line. But as we move into this volume and value-based environment, from volume to value, my question is always, I don't think we can afford not to do it. To me, it is the underpinning thing behind all these quality measures, because, for the past 100+ years, whenever people came to the hospital, we do stuff to them and then they go back home. It was like it's like ordering a McDonald's. Yeah, I'll have one knee replacement and to go, and then they go home and that's it. But when you talk about an actual value-based environment, we're responsible for the outcomes for these people. And I came to healthcare from the economic research background, and one of the things that we always talk about is the theory of the rational consumer. And I know that that's been developed in like 50 different ways, but the inherent assumption, though, is that you assume that the average consumer is making decisions that are in their own best interest, or at least what they perceive to be in their own best interest based on the limited information that they have. The problem is when you talk about the prevalence of things like depression and anxiety, you're talking about an average consumer that is incapable of making a decision that is in their best behavior, that is in their best interest. So when you talk to them about losing weight in order to get their cholesterol under control or whatever, they're incapable of making good decisions about that. So you can talk to your blooming face, you're not going to get anywhere. And I see this over and over again, and I don't think I've seen a data set yet where this hasn't been the underpinning issue with your frequent flyers. They're coming in over and over and over again. You think you're educating them, you think there's something at home, they're lonely or something like that. Time and time again, it's a behavioral health issue, it's a social issue, it's not a medical issue. So I wanted to get into that. This was a quote from a TED Talk, actually. Mental health can improve overall well-being and prevent other illnesses. And since mental health problems have a serious economic impact on vulnerable communities, making them a priority can save lives and markedly improve people's quality of life. One of the things I wanted to talk about, and this is now starting to get a little buzz, but I think it needs way more attention than it's getting, are ACE scores. These are Adverse Childhood Experience scores. This is a survey. It's scored from 1 to 10. And high ACE scores, which is like a score of like 4 or above, has been linked to a history of all these things. Two of the ones that I really want to talk about is the bronchitis and emphysema, because that is something that most people would never relate to childhood trauma in any way or any behavioral health arena. But also chronic pain. The reason that I've highlighted chronic pain here is that the state of Massachusetts actually did a limited study on piloting this in primary care offices. And what they found was they surveyed the primary care doctors before and after they started giving out these surveys. And they found that it was something like 70% of the doctors in that survey said that they could correctly identify a history of child abuse or some kind of past trauma in their patients, and less than 10% of them actually got it right. Those same doctors went on to identify what they thought the top 4 symptoms associated or conditions associated with the history of childhood trauma were. And what they identified were things like depression, anxiety, suicidal ideation, things like that. But actually the number 1 condition associated with the history of child abuse is chronic pain. As we go into this, one of the things that's interesting too, and I have another slide that goes a little bit more into depth on this, but for somebody who has a history of child abuse, they are somewhere between 70 and 80% more likely to become addicted to an opioid, regardless of if they take it correctly. So what you have is you're talking about rural providers that are already stretched thin. They're already seeing a ton of people. They've got these patients that are coming in over and over and over again, saying their back hurts or something like that. You give them an opioid, and even if they take it correctly, they're much more likely to become addicted. And so it's kind of creating this perfect storm, especially, and I think that's one of the reasons that it's been especially potent in rural America. So I pulled our data for this just as a litmus test. And so these are the top reasons for ER visits for our Medicaid population and our Medicare population. So you'll see right here that diseases of the respiratory system made up 37% of our ER visits. And here's the Medicaid, that one's Medicare. And you'll see upper respiratory infection, pharyngitis, and COPD and bronchitis, which was almost a perfect list of the things that you're talking about with those ACE scores, making up the majority of our Medicaid population, which means for 2 of our payers that make up more than 60% of our payer mix, the number 1 and 2 conditions that we saw on our ER are directly related to history of child abuse and behavioral health issues. And so from that, from our ACO data, I was able to identify who our highest risk score patients are. So our highest risk score is calculated as the Johns Hopkins risk score. The way they calculate this is basically they calculate a base average person of a certain age demographic that they think that they should cost. And then for every condition, there's a certain point value assigned to it based on how expensive it should be in hundreds of dollars. So for example, you start out with like 0, I guess, and then like after you get past 55, I think it goes up to 1. And then in diabetes, I believe it's 0.7 because they expect it to cost $700 a month. And so you add 0.7 to that, and it goes on up. And so that is how our highest risk score patients are attributed. From this list, you'll see that overwhelming presence of mental illness looks like 80% have some sort of mental illness. And the way I categorized that was either clinical depression, anxiety combo, or worse. So schizophrenia, schizoid disorders, borderline personality disorders, those sorts of things. You'll also see that an astronomical amount of chronic pain in that first column there, as well as smoking and COPD, which were other things that showed up on that. From this, I identified that we have a gigantic gaping hole in our behavioral health services, and that this is really preventing us from moving the needle on those high-risk score patients towards getting them to a better condition, because most of these patients were also our highest ER utilizers. There's 3 people on here that had been to the ER more than 20-something times, and it was only 6 months into the year. So, just a little more compelling evidence in case you need some more. This is comparing a white male with an A score of 6 versus an A score of 0. 250% more likely to smoke, 4,600% more likely to be an IV drug user, 500% more likely to abuse alcohol. And this was based on a study done by Kaiser Permanente. They did a retroactive study on 20,000 of their patients. They went on to do another part of the study that was really interesting, where they talked about Vietnam vets who had used heroin in the war, but when they come back, they were no longer addicted. But for the ones that did stay addicted, the biggest determinant was if they had a higher A score. And the study goes on to make what I thought to be a very provocative claim, but I actually really agree with. Adverse childhood experiences are the main determinant of health and social well-being of the nation. And I think when you look at this in the context of, the deinstitutionalization of mental health since, about the 1960s, it makes the drug epidemic look much different, I believe, because now I always see it, this is a manifestation of the behavioral health problem that we've been hiding for years. This isn't a new problem, it's just a more obvious one than the one that it took the place of. So, how do we pay for this, for behavioral health? I don't really have any good answers. Those are the Medicaid rates. For Georgia, if you utilize mid-levels, you can kind of break even on that. Utilizing nurses at the top of their license to initiate the PHQ-9 depression anxiety screenings. Create a process to catch frequent flyers. There was a really interesting model that used, they basically stratified their frequent flyer patients into 2 groups. The frequent flyers that had some kind of mental illness and the ones that didn't. And it was a mobile medication program that was created by a lady named Julia Wacker from North Carolina. And they found techs. And they didn't have any specific kind of certification, but they worked under direction of an RN. And if they had any kind of documented behavioral health problem, they sent out a tech to their house the next week to do med rec with an RN. And they gave them a pill organizer. And what they found was because of the lack of information sharing between behavioral health records and mental health or medical health records, these patients were going to ERs all over the place. They're getting prescribed multiple prescriptions that were interacting. They had doubles of just about everything. And they weren't taking what they did have properly. So for example, they might find that, or they might be afraid of the addictive properties of Xanax, so they were cutting it into 4s when it's not scored for 4s. So some days they were getting a ton of medication and some days they weren't getting any. And then when their medication gets out of whack, they come back to the ER. And so I would say we've definitely seen that in our community, so that was one model. Other than that, utilizing telehealth for this purpose would be really good as well, just because it helps you make the most out of limited providers, especially if you can't afford a psychiatrist, because we don't have a psychiatrist.
They're Microsoft.
Yeah, no, I don't really know what to do about it.
Just
Hello?
The battery.
Yeah,
What's that?
Battery down.
there's a,
Three
you
batteries?
can put it on, you might hit, but you can also lean into the mic.
It's not muted, it's just going in and out.
All right. Any battery?
So before we go any further, I was going to ask, how do you think that Georgia does on opioid prescriptions versus the rest of the states? Do you think you're better, worse, or average? Okay, who thinks that Georgia is one of the worst states in terms of prescriptions, over-prescribing opioids?
How are you defining worse?
So number of prescriptions given per people.
I mean, in the top 10, top 20,
Yeah.
above the median,
Yeah,
above the median?
yeah, we'll say above the median.
That's a lot.
All right. How many people think that you are average?
Right.
How many people think you're better than average? Actually, pretty good. Guys are okay, especially given, you know, everyone around. So,
What's that mean? What is it? Oh, yeah.
Well,
states
every other
around-
state
oh,
around
the states
us.
around us, yeah.
so one of the things that I wanted to talk about with this, though, is just because you guys are less than the states around you, actually, you've got some areas that are dramatically pulling you down and some that are doing much better. And as I said before, I have the prescribing data on all your physicians for last year, and so I was able to get in and really drill down into this. This is really important because it's really important for telling your story too. And I'm going to get into a lot more detail about this as I go through here, but it's kind of off the side, ain't it? It's in your packets. That's okay. So as we drill down into this, you'll see what I'm talking about. I'll just wait till I get there. All right, so for this first data set, what you have here is these are all hospitals that are in this room from 1 to 11. And then the average Medicare claims is how much that patient where Medicare had in spend per patient. So how much the average Medicare patient at that hospital incurred cost. And then the next thing is the drug cost. Average drug cost across the entire facility for their Medicare population. And then in the last column, you have your average beneficiary number. That's the average number of Medicare patients that are primary care patients of everyone's doctors. And so one of the things that really jumps out about here is that you'll see that the top line, the green, is for the average of those 11 hospitals, which are rural. The bottom line is the Georgia average. So one of the first things that I will point out is that you'll see that the average is higher across rural. The cost is higher. The Medicare claims are higher and the drug cost is much higher. But you also see that the average beneficiary number is much higher. The average rural doctor is seeing almost 100 more Medicare patients. So there's really two possible explanations for that. Either our docs are overworked and our care is overpriced, or our patients are disproportionately older, sicker, and poorer than their urban counterparts. And as we get into this, I can show you that too. But this right here is the average antibiotics. So this kind of goes to the quality of care that I wanted to talk about. You'll see that on the whole, that rural providers are writing more antibiotics, but they're seeing more people that need antibiotics. And the cost is about on target, but you'll see over in the corner what really tells the story is the antibiotic rate. So while they're seeing a lot more people who need antibiotics, therefore sicker people, they're actually prescribing at a rate that is identical to their urban counterparts. So there's that. And actually some of these guys are better than their urban counterparts. Some of you are performing much better in terms of antibiotic stewardship. And this is really important too when you talk about the fact that, you know, I feel like rural, everywhere I go, actually yesterday I heard Chris Christie just beat the crap out of rural providers saying that, well, you know, they see so many patients, they'll just give them antibiotic prescription to keep them from coming back, or to get a good Press Ganey store, they'll give them an antibiotic prescription when they don't really need it. And to that I say, well, I don't really know what you're looking at because the numbers aren't showing that. You're much more likely to get an antibiotic prescription when you see an urban doctor. Then we get on to the opioids. Now, on the whole, we're about on track with between rural and urban Georgia. But what you'll see over in the corner is the rate of opioids prescribed for some of the communities are much higher. I will say that has played out in several communities. you got, like, for example, there's one provider in one of your communities that's prescribing at a rate that's 4 times what anybody else in a family practice setting is prescribing. I don't really know what's going on with that. There might be a reason though, but it's probably worth knowing. And if I haven't said this yet, I have a data packet for all these hospitals. I put together a whole bunch of stuff. There's a whole bunch of stuff in this. I just couldn't print it because it was so many pages and there's a lot of you here and it was going to kill a small forest. So I'm going to give you all my card. Email me and I'll send you everything I've got on you. But, so I've got the names of those doctors. I can see what they're prescribing. But on the whole, you'll see that rural Georgia is holding track with urban. And that some of these higher ones, for example, the one that's like 9, it's hospital number 2. It's a volume issue more than anything. There's not a lot of people there, and so it makes it look worse. However, I think the real story comes from that last bit of data. I wish you guys could see it better. So for example, and I could point out several, but I'm going to start with one. Hospital number 8, which is in this room. I think this is an absolute, just like a microcosm of rural healthcare. So you'll see their average risk score for that patient is 2.5. The average risk score for a patient in Georgia is 1.3. That means that patient has so many illnesses that they should cost $2,500 a month for their health care. And that would be off the charts. So I'm thinking for a patient to have about a 2.5 risk score, they would have to have diabetes, hypertension, probably like CHF, COPD, things like that, all combined, all at the same time for them to hit a 2.5. And this is the average patient that these people are seeing that is of the Medicare age. You'll see from that too that they also have a much higher rate than average of dual eligibles, which means not only are these people really sick, they're dual eligible, which means they're also very poor. The average urban doctor sees 119 dual eligible patients, where this particular community has 181 dual eligibles. However, when you scroll over, I guess we're not scrolling because we're looking at the paper, but you'll see that the average claims for this facility is $13,000 a year, where the average claims for the state of Georgia is $5,000. But if you'll recall from that risk score, the average patient there should be cost 2.5 times what a normal patient costs. But the actual charges are only like $3,000 or so above. Well, I guess it's at 2 times. So basically, you're providing a very high level of care for a very low cost. You'll also see that a lot of that charge is actually spent on average drug costs, which is much higher, which means that these patients are getting the prescriptions they're supposed to get, they're getting them filled, and because of that, their charges are much lower than you would expect. If this hospital was in an ACO shared savings program, they would be rocking it, because they are providing much cheaper than a level of care than they're allowed to provide, if that makes sense. And that's the sort of data that really tells a story for rural America. This is the sort of data that I would like to see everybody.
Question, when you said that it's providing care at a much lower cost, is that based on cost off the cost report, or is it based on charges?
Charges.
On charges. So
Yeah.
if their charges are not brought up to date forever, then that's a problem. Okay.
Well, this is money that's actually went out the door. So this is money that Medicare has put in your hand. It's
Okay, so
done.
this is net
Yeah.
reimbursement.
Yeah.
So it's not
Yeah.
charges.
No,
Okay.
sorry.
That's okay.
I get what you're saying. No, yeah, no.
Okay.
Yes. I didn't know if you were asking if this is internal or external data. This is money in hand.
Money in the checkbook.
Yeah. Another thing that's really important too is that all these communities could be seeing patients that are at a 2.5 risk score. It wouldn't shock me one bit based on some other things I've seen. Critical access hospitals don't have a lot of incentive to correctly document every single condition every single time because they're not based on that. Their reimbursement is based on cost. And so what happens is if you don't drill down to the nitty-gritty on every single patient, then that patient doesn't have the appropriate risk score. So it looks like your patients are healthier than they are. And that works against your outcomes as well. So for example, we ran into that at our hospital when it looked like we were straight up killing people with pneumonia, because our outcomes looked like everybody who had pneumonia and walked into Margaret Mary died. But actually it was because we weren't correctly documenting that they also had stage 4 lung cancer every single time they came in. And so, and that affects the risk score, and that also affects the outcome that Medicare expects to see, and that's what this data is based off of. And so part of also telling your story is making sure that you get that documentation absolutely correct. So you can go to your elected officials and say, look, we have the most poor people who are also Medicare eligible. They're extremely sick. We're taking care of them much cheaper than urban hospitals. You don't want to shut down your rural hospital and have a freestanding ER where you're shipping them to urban, because they're immediately going to cost what urban patients cost, which is much more, and those people are much healthier. So just imagine what your costs are going to do, not even addressing the access to care issue. And so another reason, I also hear people ask, when I give them the opioid data specifically, how do you address this without interfering with a doctor's, sovereignty, I should say, without interfering with care? I don't think you have to interfere with care, but this is one example. This is near my home community. This was last year. This doctor was arrested for fraud, for dramatically overprescribing opioids. They talk in the article, which you can't really see very well, about how many, that he was one of the most expensive opioid providers in the country. It was an absolutely crazy case if you wanted to read it. But I guess the point I'm trying to make is these things are still out there. I hear a lot of people talk about it like pill mills are a thing of the past. They shut that down. It's not. You don't probably want to be the place that finds out that the doctor in your community is, you don't want to find out from the news that this is what's happening, because it's what happened to their community. And even though this guy was only loosely affiliated with the local hospital, everybody assumed he worked at the local hospital, because all healthcare providers are the same when you don't know any different. And so then, it just had dramatic effects on the rest of the community in terms of how people saw their doctor, that they trust their doctors anymore. Are doctors causing the opioid epidemic? And so, I guess, best part about the opioid data is, I'm not saying that you need to necessarily go in and fight with your doctors over a 1% increase in opioids, but you don't want to find out from the news that this is happening in your community. And I think there's a middle ground there. I think there's a way that we set up guardrails with our doctors, that we work together and say, okay, what is an appropriate amount? How do we know when somebody is going off the deep end? And so, other than that, I have all kinds of data. I have, like I said, all the prescribing data. I have for every doctor, all the way down to the doctor level. I can benchmark that county, region, across specialties, across the state, for antibiotics, opioids, antipsychotics.
Nikki, before you wrap up and give them access to all the data, can you hit the ACE score just one more time?
Yes, you can.
What actually is included in that? What is the list? Where are the list of things in that ACE score? No,
What's the questionnaire?
Yeah, what's the question?
Oh, okay, so it's basically asking about, it's a survey, and it asks things like, did anybody in your household make you feel special or loved growing up? Did you feel like you had someone who supported you growing up? And then the obvious, did anybody hit you growing up? Things like that. It ranges from, emotional support all the way up to, physical abuse in the household, and it's on a gradient from 1 to 10.
Do you have a reference for it where people could get it?
Yep. It's readily available. It's everywhere. Online, you can just type it in, they give it out. So.
Other questions? Yes, Dr. Nesbitt.
Do doctors get this prescription data about where they stand?
No.
Because, where surgeons get feedback on their complications and the mortality, they find out they're outliers. Generally, they respond to that and try to do something about it.
Yep.
And I wonder if people would respond to their drug data in the same way.
That's been my experience. That, our doctors, we had one in particular who took it real hard when she was on one of them. So, we've implemented a lot of opioid reducing strategies and different things like that across their organization, and a lot of it has been kind of in response to the fact that this data is out there and now we can see it. We can see where we are.
We certainly saw a physician response when they started publishing the amount of money doctors were getting from drug companies and appliance companies and other things. And it's like, no, not me. Yeah, it is you. Transparency. Other questions?
Nikki, when you looked at the prescription data and the opioid prescriptions, can you correct for the number of pills that were prescribed?
Yes.
You can?
Yes.
Okay.
Yeah, and it even shows, too, the number of 30-day supplies given out, because now, a lot of states have requirements that, especially for first-time prescriptions, that they can only have like a 3 or 5-day supply or something like that. If it was a condition that would have normally required a 30-day supply, then that means that that's multiple prescriptions that are showing up on that doctor when it might have been a small prescription. So it also pieces out which ones were 30-day supplies and which ones were the smaller supplies too.
Help me understand your data source again.
I have a lot of data sources. The opioid data in particular, is that what you're asking?
A couple of things, yeah, the opioid data for one, but also your hierarchy scores, your average risk score and that piece of it.
So that all came from CMS.
Which data source out of CMS?
They just gave it to me. It's a big old raw data set.
So it's your ACO data?
No, although we do get this through the ACO.
Okay,
We do, but I don't get your data through the ACO.
okay,
So we get our data through the ACO.
okay.
So
So this isn't Medicare claims database, inpatient outpatient database, Medicare?
yeah.
It is.
Yeah.
It's Medicare.
That everybody has
Oh.
access to.
That's,
No, it's not MedCard. I'm sorry.
Okay.
it's a claim.
No, I gotta be honest. They
As
publish.
a researcher at university level? Is that-
They publish the older data. In order to get the
Right.
newer data, I am not proud of this. So they wanted like a lot of money for it, and I didn't want
Stop recording right
That's
now.
why
I didn't want to pay a lot of money for it.
Yeah.
So I just started calling them relentlessly at all hours of the day. And I actually did it on accident last year. And then I had a bunch of people tell me that they couldn't give it to me without paying me. And then one of them slipped up and sent it to me. And then I had the data right at that point. I'm like, oh, wait a minute. And so this year, when I wanted the new data, I just started calling them at all hours of the day and then emailing them at the same time, hoping that I would once again find another weak link who's going to send me this data. And, I thought I was being slick. But then finally, I sent them this big long email of this emotional plea, I do this data for all these hospitals in the country and I give it to them and they can't afford it on their own. Nobody's going to pay multiple thousands of dollars for this data set. All this, and this is the only way we have to monitor this. And they respond back, just take it, period. And every other email I've ever got from CMS is greetings for the Centers of Medicaid and Medicare Services and all that. This one was literally just take it.
Did you work for Rush?
I think Nikki made a very important point when she talked about the importance of documenting severity of illness. And I think critical access hospitals took a pass on that because it didn't matter. It didn't impact it didn't have an immediate financial impact. But just to use a comparison, I sit on the board of an FQHC, and I'm involved with a lot of critical access hospitals. FQHCs have for years had to report data on performance. Critical access hospitals, not so much. Political environment, who has the biggest advocates? FQHCs. Who gets the most rocks thrown at them? Critical access hospitals. Because there's these accusations, whether they're based on reality or just faulty data, that the quality of care is more expensive than it ought to be and not as good as it ought to be. So I think it's incumbent on us to try and figure out how do we ramp that up? How do we get it right? Because if those stories are not right, based on the data that we're providing, we need to tell a better story. Fair enough?
Well, and those that are reporting the data, they need to quit limiting not enough volume, and then you get the star. So the volume is what the volume is.
That's
You know,
right.
we don't have 600 beds, so our numbers, of course, are going to be small. But those 10, maybe that we did do, put it out there, but just put, with the potential or something. They need to either prorate it or percentage it or something. But the volume that we do have, everyone thinks you're hiding something when you have all the stars. But a lot of it is the overall volume doesn't meet the minimum requirement that they won't report. But, what they don't know, they'll make up. So I'd rather them know the facts versus the, Yes, he must.
And I've seen some regular small rural hospitals, not credible access, celebrate the fact when their threshold dropped low enough they didn't have to report that anymore instead of taking the approach that you just identified, which is we need to continue to report this. We've got to tell that story regardless of whether it's required or not. So.
And I can get a lot of that data even if you're low volume. So if it doesn't show up like on Hospital Compare, I can still get that.
How many board members do we have in the room? 2, 3. Let's give them a hand. And thank you, Nikki, for that. That's great. You poked a bunch of skunks. I think you're going to get a bunch of emails requesting information.